everybody. We are thankful that you are here this morning. During this week, the Ministry of Health, Wellness and Elderly Affairs has been working with a consultancy firm, that is JIPA Network LLC. They've been hired under the government of St. Lucia through the Ministry of Health to provide technical assistance when it comes to UHC financing. Okay, so this week we've met different stakeholders discussing the UHC financing policy, and then you are one of the important groups, credit unions. So we're happy that you're here this morning. But to start off, we'll have a word of prayer, and I'm going to call Miss Patrice Lewis, my UHC Monitoring Evaluation Officer, to lead us in prayer, and then we'll continue this session. Thank you. Patrice?
Let's just bow our heads in prayer. Heavenly Father, we thank you for just the breath of life this morning. We thank you for the opportunity to come here today to have breath in our lungs and to have our two legs to be mobile. Lord, we pray over the proceedings of this meeting. We pray that it will be productive and that everyone's voice will feel heard. We thank you for the credit union represented here today. We thank you for JIPA that has come on board with us, Lord. We pray that we will continue to push the agenda of UHC forward and that it would be represented in a way that it truly needs to be amongst our society and that it would be received, Lord. We thank you for this opportunity and we give you all the praise in Jesus' name. Amen.
So for the purpose of this discussion, we'll do some quick introductions so we know who is in the room with us. I will start off with myself, Alicia Eugene Ford, Director of Universal Health Coverage.
My name is Diana Leo, St. Lucia Cooperative Credit Union League Limited. I am the Research and Business Development Officer.
Nadel George, Financial Regulator on the Insurance and Pensions Department of the FSRE.
Morning, Charles Itoville, Senior Financial Regulator in the Insurance and Pension Plans Department of the FSRE.
Good morning, Rosemary Rennie, St. Lucia Teachers Credit Corporation Compliance Officer.
Good morning, St. Lucia Cooperative Credit Union League, Vinil Jacob, Administrative Officer.
Thank you. Good. We have some other individuals here in the room with us. They're not from the credit union, but we'll just allow them to do some quick introduction to say their name. Okay.
Natasha Claremont, I'm from Accela Marketing.
Agnes Francis, Accela Marketing.
Thank you. And the team from JIPA.
Castor Ned, I'm the CEO of JIPA Network.
Hi, good morning. I'm Alvin Holas with the JIPA Network team.
My name is Kassan Buddy. I'm the VP of Operations for JIPA. And we're also wishing Ovine a happy birthday.
Happy birthday.
And I'm Weber Boer. I'm also with JIPA.
Thank you very much. So to start off, we're going to do a quick introduction, a quick presentation on universal health coverage to know where we are, what we're doing under UHC recently, and then we're going to hand over to JIPA so that they can go into the UHC financing policy. There are certain things that we have to cover under universal health coverage when it comes to phase 1 of universal health coverage. But just to start off, I want persons to be clear that universal health coverage is aimed at increasing access to quality health services, ensuring little or no out-of-pocket expenditure. To do so, we have a broad range of health services that we want to give the public citizenry of St. Lucia within a basket, which we call the essential package of health services, and the plan is to roll it out in phases. But every single service we give out, it has to take into consideration promotion, prevention, treatment, rehabilitation, and palliative care. And that's very important. So under phase 1 of UHC, there are things or activities that we were tasked with as the UHC unit. First of all, we had to create the UHC unit, which is something that's already created. We had to look at implementing hypertension and diabetes screening and treatment under the performance-based financing pilot project. And just letting you know that this is a project that started out, and we started providing services in August of 2023, okay, where we started with 8 facilities in rural areas, and now we expanded to 9 more, making it 17 facilities in rural areas like Dennery and Micoud, and some of the areas like Canaries and Lakwamingo, Vanna, and all these places, Jacmel, Slurry. Okay? We also have to do looking at inclusion of dialysis and early cancer.
And not only use of Lucia, that currency, but also islands of St. Kitts Nevis use the same currency as we do here. St. Christopher and Sarat use the same
early cancer. I guess you've been hearing me. Yeah, registration of the population, creation of a UHC unit, which I spoke about. We have to do creation of a UHC special fund and a comprehensive PR strategy. On a lot of these things, we have started working on it. Some will progress further than others. When I speak of the essential package of health services, I want you to get an idea of which services we have within the basket of services, and we're looking at services such as what's actually making us unwell in St. Lucia and what's killing us as well. So we're looking at hypertension, diabetes, and their complications. Okay. We have other diseases, of course, like cancer. We're looking at breast cancer, which is very common in women, the lead cause of cancer in women. We have prostate cancer for men as well, colorectal cancer, cervical cancer, gastric cancer. We continue our maternal and child health services. We're looking at mental health, which is very important as well, oral health, eye health, injury and trauma, and HIV and TB and all the other communicable diseases, just so that you get an idea of some of the services we have within the basket of services. All right? Letting you know that we started maternal and child health services in June of 2023. And just to give you an idea of what has happened, before we started the service, we wanted to compare a period of time when we started before we started the service and compare it to an equal period where the service for maternal and child health services existed. When I say maternal and child health services under UHC, under UHC, what we've done is that we allow, or we decided when women who are pregnant, expectant with mothers, they could get all the lab tests and all the ultrasounds at no cost to them through the wellness center. Okay? So we compared the period before we were offering this, which was, we took the period of June 2022 to June 2023. We were not offering this at all, and we had about 1,499 women going to the wellness center. But then when we compared it to June 2023 to June 2024, when we offered the service, you realize the numbers increased, which means that women were actually coming to the wellness center for the services. And that did not exclude the women from the private sector, because we noted the importance of having the relationship with your physician. So if you have a private physician that you are comfortable with, we will not tell you to leave the private physician. This UHC would not encourage this. So therefore, we will encourage the private physician that if the patient wants to access the services to the wellness center, they can do so as well, as citizens of St. Lucia. We also started cervical cancer screening and HPV testing. We have been doing cancer screening for eons in the primary health care. But what we decided to do is that we changed the method where we're using liquid-based cytology, and we can do HPV testing, where we can find out the strain of human papilloma virus that caused the cervical cancer. And the women are coming. We started in August of 2023, and if you compare August 2023 to November 2024, we have 1,577 women who have already come for that test, and the numbers are growing. I did mention the performance-based financing pilot project, which we started in regions that are rural, certain regions, rural areas, and we had 25,168 people above the age of 18 actually coming to use this service, which represented 53% of the population of these areas. Okay. We have 1,837 were diagnosed with hypertension, and 1,030 were diagnosed with diabetes. And that's in the period of August 2023 to October 2024. We did not forget our men, okay? We know that the men are persons with a health-seeking behavior that is different from women. However, we have relaunched men's health clinic under UHC. And what we've noted is that the men are coming to be fully examined. They also have the option of getting PSA checks, prostate ultrasounds done if they have to get their prostate ultrasounds done, and a urologist review or reviews if necessary. Okay, from December, we started, from December 2nd, when we started some of the clinics, into January 18th of this year, we already have 108 patients, male patients. And the numbers are increasing because the men are calling to get themselves checked, which is a very good thing, okay? We would not be able to do UHC without having public-private partnerships. So therefore, the labs we engage to go to the wellness center, they're coming from St. Jude's, OKUH, and Lab Services and Consultation Limited. They've been coming across the wellness centers to ensure that these services are right there within the community. We also have engaged ultrasound service providers on island, and we have a series of them. Actually, we have 7 of them that we have engaged so far. You see 6 there, but we added 1 recently. We have Le Clinique du Corps, who's on board as right now. You can get your ultrasounds done there as a woman, or prostate ultrasounds done as a pregnant woman, and a prostate ultrasounds can be done for men at these facilities. And we're looking at anyone: Helen Diagnostic Center, Medical Imaging Inc., Rodney Bay Diagnostic Center. We have Get Well Clinic. We have Cable Woods Clinic. Okay, we have in the South St. Anthony's Medical Center. Medical Images as well has a southern branch. So all of these areas, including a Soufriere branch of St. Anthony's Medical Center is there. So we're trying to ensure that all the different service providers on island are engaged. Okay, so just letting you know, we have had women coming and we have ultrasounds that are being done. Just for June 2023 to November 2024, we had more than 2,955 ultrasounds being done. Quickly letting you know, for every single UHC, not for every, but everything we do in UHC, we have to ensure that a series of activities are being done. But we have to take into consideration UHC financing. We cannot do these activities if we do not think of how we're going to finance and sustain. And that is why we're here today, to see what the UHC financing policy speaks of. So I want you to really focus today on the UHC financing policy and to give your feedback, especially as credit union persons, okay? But just letting you know, this is something that we've been working on simultaneously. We've been also doing training sessions so that every single time we have what you call a service to be launched, we have training sessions being done, not only for the private sector, primary healthcare and the hospitals, but the private sector physicians and clinicians. PR and communication is something that we're doing ongoing. Some of you may notice we do media blitz, where we go to a series of media stations. We actually have display on the billboards. We actually go down in the community. We do leaflets, pamphlets, and we try our best to ensure that the community is informed of what's happening. Okay, we do it in English and French Creole, and at a community level, so we even use the horn, the town crier. Sometimes, depending on the community, we use what works best for them. We have service levels agreements and private contracts that we have to engage people in, because at the end of the day, we know that to be able to deliver UHC, you have to bring the private sector on board at times. Stakeholder consultation, community sensitization, and of course, internally, we have to develop our key performance indicators, standard operating procedures to make sure that we deliver quality care, but we're monitoring what we're doing. Okay, and that is something that's simultaneously going through. Just letting you know, for every single thing we do in UHC, we have to constantly think service delivery, human resource for health, UHC financing, how we're going to do health information systems, legislation, governance, equipment, drugs, and all of these things we have to think of, because all of these are important health cares for UHC. So today we have a very important health pillar that we have to look at to be able to deliver UHC, is UHC financing. And as a result, I'm now going to hand over to Dr. Kester Ned, who's the CEO of JIPA Network LLC. He'll tell you a little bit about JIPA, but as I said earlier on, JIPA was engaged or brought on because we needed what you call technical assistance to be able to work and to deliver on UHC financing, and they have the expertise to do so, and therefore they were contracted to work along with us at under Ministry of Health. So without much further ado, I would like to put our hands together for Dr. Kester Ned, who will now speak on UHC financing. Thank you.
Well, good morning, everyone. I appreciate you all taking the time off your busy schedule to come here and listen to this very important presentation. So I first want to recognize and thank Dr. Eugene and her team for her efforts in helping to take this initiative to where it is today. Without the healthcare component of UHC, even though we may have put a financing program together, the consumers want to know that there is a product that they could access. And certainly the efforts to strengthen the health system must run in parallel to any kind of financing structure or infrastructure that we will put together. So myself, I'm actually a physician by training, but I've had an extensive experience working in the Caribbean with helping people get access to healthcare pretty much that might not be available in your country, in our countries in the Caribbean. I'm originally from Grenada, but I've practiced in the US for many years in Miami, Florida. And I've worked with various Caribbean nations in helping to conceptualize and implement national health insurance, similar to what we now call universal health care coverage in St. Lucia. So this is the process that governments must go through. This meeting is one example of such consultations that we encourage all of the stakeholders to participate. This week we've had already, I guess, about 9 or 10 meetings. This is the 13th meeting that we have meeting with various groups. We've met with doctors and policymakers and the unions, and today, this morning, this first session is with the credit union. So we look forward to your participation, and it's truly a consultation. I'm going to speak about what we're doing, but we also want to hear from you about your ideas. And some of you might have already seen the policy document that was sent out. I don't know if you've had a chance to review it or see it, but a lot of work has been done in developing the policies around the implementation of a financing program. So today, what we're going to talk about are the principles under which healthcare financing in UHC could occur in St. Lucia. So we'll first talk about issues that we face in healthcare financing in St. Lucia. By the way, not unique to St. Lucia, but the entire Caribbean and some other parts of the world. Why universal health care and why now? What will success look like? And finally, how will the financing be developed and implemented? We don't have all the answers, and clearly what's been proposed, there are opportunities to yet make modification. The plan is that once this gets past the consultation, it will be presented to the cabinet and also to eventually to the Attorney General's office, where legislation will be drafted. We've had some experience doing some of the drafting and working with other Caribbean islands in developing this. And so there's been a lot of work done, not just here with this team, but work done outside. So we'll start by first telling you that we have taken what we would call a stakeholder approach to this. Very important that the voice is heard because it matters. Second, we're looking at this as a nation-building exercise. Why is that the case? This financing program must survive all of us in this room. Why? Because this is the future. Any one of us sitting here today could suffer from a catastrophic medical condition that could compromise our ability to support our families, and let alone compromise our ability to finance our future. One of the major causes of poverty in the world today is having a medical illness. And it doesn't bypass any one of us. It could be our parents, it could be ourselves, it could be our kids or grandkids. And when that happens, everybody must come together to ensure that that person gets through that process. And certainly what we want to do is to create a better environment in St. Lucia so that we could help our brothers and sisters through this process. So we're speaking about a collaborative, integrative type of approach that involves all of us. A major part of this involves collection of information, what we usually call data, to make decisions about what should be done. And certainly that's one of the areas that is planned in terms of further development. The idea of transformation and integrating with new concepts and ideas is critical to the success. Certainly, the issue of privacy and patient rights are also important. Rights from the standpoint, your information is private. And while we need to share it, but we must share it with the appropriate people. Currently, most information in healthcare is in paper format, not in electronic format, so it's not portable. And as a result, there's a lot of duplication of effort. And so we'll talk about how we could modify and change the efficiency. This is an adage from the Asia context, where if you're blindfolded and you ask to touch a part of an elephant and to identify what the experience is like, what you're feeling, most individuals would define the experience based on what they feel at the moment and what they see. And we use this illustration because it's so important from a contextual standpoint to understand how we as stakeholders perceive funding of healthcare and healthcare itself. So if you're looking at the tail, you'll think it's a rope. If you're looking at the main body, you'll think it's a wall. If you're looking at the tusk of the elephant, you'll think it's a snake. So the point being that without having the entire picture, all of us could come at this with a different impression. This is what healthcare and healthcare financing is about. And why is that the case? If you're a doctor, you have one perspective. You're concerned about, obviously, services. You're concerned about training. You're concerned about how you're going to be compensated for the work that you do. If you're an insurance company, you're concerned about the regulators and whether or not you meet the standards to stay in business. Because if you're not running out of profit, they're going to shut you down. In addition, you're also concerned about how much dollars are you paying out, something called medical loss ratio, meaning how much dollars you're paying out for medical care compared to administrative and other things, and what's left. And if you don't have enough, you're not going to be able to exist. So there are conflicting elements of this between the hospital, the doctors, and the insurance company. One, you want to hold on to the cash that you have. The other one, you want to pay it out. So, of course, that represents some kind of conflict. If you're a consumer, you're concerned about the fact that you need your healthcare services paid for and you don't want to have to dip your hands in your pocket and pay for it yourself. So all of us have a point of view that conflicts in this area. And this is what this slide is talking about. So, I don't know if it's time to... So we want to give you guys a chance to participate. And this QR code, we want you to point your iPhones to this, and there are a few questions that we want to give you guys a chance to answer. So, Cassandra.
Hi, everyone. So the purpose of this is so that we can measure not only how you feel about the current healthcare system, but specifically for your communities that you represent. So there's only 3 simple questions that are part of this survey. It takes 1 minute, but it's super important because out of all the groups that we've met with and that we will be meeting with, we've already gotten a little over 100 respondents from the groups that we've met with. So your voice is super important to the dialogue. So if you point your phone, it doesn't have to be an iPhone, any phone that's at least smart, you point your camera towards the QR code. It's an anonymous survey, and you'd be able to fill that out. This particular group is group number 13. So that first question that it asks, which group are you a part of? You would select number 13 for credit unions. I see that we also have some individuals from the insurance sector that are here, so you can select that one if you'd like, or for another group, please. 14, go ahead, put 14. Apologies, thank you. And actually, you know what, that's right, because we kind of switched the group number that you guys were in, so thank you. All right. And we can go through those questions together. Okay, perfect. We have some tech-savvy folks in the audience. Perfect. So just keep in mind for question number 2 and number 3, it's multi-selection, so you can select all the things that you think apply. And for the last question, keep in mind that if you don't see the issues that you think are applicable, you still have the opportunity to add other. So if there are things that you think are important that need to be raised in regard to the healthcare system from your perspective and from your communities, you can note those as well. Okay? We'll just give it 1 minute and then we'll move on.
So we've taken an approach to this where we individualize your opinion. And that's why we meet with various groups at a time, so that you get a chance to have an opportunity to present your perspective as a stakeholder. And mind you, we don't have all the others together in the same room. That way you could get your perspective felt. Of course, we're going to have further sessions where we'll have general audience, but being that you are a critically important group that represents a very large percentage of the population, at least from the credit union and financing side of things, since that impacts on the public that you serve, we thought it would be important to have you all here in the room. So now, let's see if we could tackle some of the challenging issues with healthcare financing from the perspective of St. Lucia. So, let's talk a little bit about challenges first, and then we'll try and see how we could overcome and solve some of the healthcare financing challenges based on the model that we've put together. First, the current healthcare system in St. Lucia, and what I will say is the rest of the Caribbean, is siloed. What that means, we have inherited from the colonials a system where we are apart from each other. We don't integrate well. We don't share information in a way that allows for a level of efficiency. So what do I mean by that? You have the public system over here, and then you have the private system over here. You have the public patients, and you have the private patients. And in many ways, we are siloed. Sometimes competition is good, other times competition is not so good, because we dilute ourselves in a way that we cannot reach economies of scale and we lack efficiency. And healthcare is one of those industries where we must come together. So part of our challenge is that, part of the challenge we have in a small society with 180,000 people, what they say, united we stand, divided we fall. And that's a truism here in this situation. And we'll talk about why this is the case. So this type of silos that we have embodies an opportunity that prevents us from transformation or being able to transform our healthcare system. And here's why. All right, first, we construct models to protect various elements of the system when you are siloed. And here's how we do that. So if you are in the insurance industry, all right, the way we finance healthcare is we use something called the premium benefit arrangement. It means that for a set of benefits that you offer, right, you pay a fee, right? That's your premium. And you'll cover this or you'll not cover that, and so forth. Well, here's how this works. The more benefits you use, and the more benefits are covered, is the more you pay for it. Make sense? Now here's the problem with that. If you're above 60, above 65, or you retire, you're going to utilize more benefits because you are more likely to have an illness as you age than when you're younger. So of course, insurance is designed to cover people that are not going to utilize or overutilize the service in order for them to be solvent. So here's how we fix the problem. We say for people above 60, 65, 70, we either not going to cover them or we're going to only cover limited benefits. Now, there are a lot of young people in this room. You're not at that age yet. But believe it or not, you have a parent, a grandparent who fall into this category. People that work all their lives, and all of a sudden, their little savings that they put together is now being consumed because of a medical illness. And by the way, even though you're young, you may have to dip your hands in your pocket to support your mom, your grandparents, or a sick child that you might have. So clearly, the model is designed to exclude people with pre-existing condition and to exclude people who are of age or retired and are not covered. So does that work for St. Lucia? Absolutely not. Okay, and of course, even for those who have the benefits, those benefits are limited because the premiums don't rise enough to be able to support what you really need. So in other words, we have a healthcare system that's financing diseases that you're not likely to have, and it doesn't finance the diseases that we have. So for the people that get strokes and get heart attacks and get certain advanced type of conditions, we limit the coverage. So it's discriminatory in a sense. You have one set of services that are covered and others are not. Bear in mind, there is always some kind of limit. No matter whether you have the best insurance policy, it can't always cover everything. But at least you want to cover the diseases and the conditions that we have. So one of the first things we got to figure out is, how do we do that? How do we cover the diseases that we get on a day-to-day basis? How do we cover the pre-existing condition? How do we cover those people that are retired or of age and fall into a situation that they need health care? Okay? So here's another problem. Now, first of all, this is called the benefit premium model of healthcare financing. Okay? The second problem we have is that in our countries, only 12.2% of our population have health care coverage or health insurance. That's really low. Okay? So it means that either the government is going to cover it or you have to pay for it out of pocket. And here's another problem that we have. The tax base in St. Lucia is not sufficient at this moment in time to cover and pay for the services in the public system and or the private system. Okay, and here's why. One, we don't like taxes, okay? And two, there's a huge informal economy in St. Lucia. What that means is there are a lot of people that have businesses that work and don't pay their fair share of taxes. So what we contribute to the healthcare system is rather limited. The people that pay NIC are in the middle class and the lower middle class in terms of the wages that they pay towards, say, like an NIC. And in a lot of countries, how healthcare is financed? Between the employer and the employee. Well, because you look at the people that are in NIC and the dollars that they make and what they have to pay, putting that extra burden on them from their employment and their wages does not make sense. Because now you have to decide between your kid's school book and paying this extra amount. So it's very challenging for small nations like ours to be able to come up with a system to handle this. Of course, we have a huge informal economy And we don't have the ability, either from the government or other ways, to be able to get those people into the system to pay for the healthcare services. So if you don't have a way of paying for healthcare services, the healthcare system, investing in the healthcare system represents huge risks to the people that build and operate healthcare. So one reason why your healthcare system is in a state where it's either stagnant or is not growing. Now, contrary, looking at St. Lucia, as much as you hear negative things in the press, you are way better off than many of your Caribbean neighbors. And we applaud the work currently done by Dr. Eugene and her team to move this forward. But when you sit in the position where you're in a long waiting line or you're having a problems getting service, it does not matter. That's what you're feeling every day, especially when you have to dip your hands in the pocket. Next problem, brain drain. Okay, because of our mechanism and methodology of compensation and the state of affairs in employing healthcare workers, we have a huge brain drain from the region, not just St. Lucia. So we have a hard time keeping our nurses. We have a hard time keeping our doctors. And all of the other professionals that are necessary to keep the system going, they are offered a way better wages and opportunities in other countries. So therefore, it's very difficult to have a sustainable system. Another factor we don't pay attention to is the fact that the past and current generation of the people who build and develop the health systems, when they die and they leave, there is not another generation to pick up and hold those together. So what happens? All that labor and that work deteriorates, and we have to start over again. So we're talking about labs, pharmacies, other healthcare institutions that we don't have the ability to achieve sustainability. The other issue is that from a healthcare financing perspective, right, our system is a budgeted system. It means that we budget every year and we say, these dollars from the consolidated fund in the government, we allocate to healthcare. And we don't have a system of cost accounting. What I mean by that, our system is not built on what things cost and how much we compensate relative to what it costs. We don't have a system of costing healthcare today. Now, you're in the financing industry. You know about profit and loss. For everything there is a cost, you have to balance it with the revenue. And if you don't have a system like that, we're going to bust, right? It's not going to work. So obviously, healthcare must be subjected to the same economic concepts and principles. So at this point, just to think that for every single dollar that a St. Lucian spends on healthcare, 37 cents comes from your pocket. That's a lot. In many countries, 3, 5, 7%. But when you're paying 37% or 37 cents on every dollar, what does that mean? You're going to sacrifice something. Okay? So if you're going to have your blood pressure medication versus your kid's school book or something else for the rest of the family, you're going to make that sacrifice and not buy the pills. Or you're not going to get insurance. I mean, because again, most people feel that insurance don't cover all the things that they need to cover, so therefore they might just say, I'm going to pay on my own. All right, so that's what the regular St. Lucian is faced with. And to make this even worse, the people that are in the most wealthy category have the lowest out-of-pocket expense. And the people who are in the lowest income have the highest out-of-pocket expense. Why is that? If you have dollars and you have money, you could go ahead and buy an international policy. You could pay for a more expensive insurance that covers more. So, in a way, universal health care is way out of the reach of developing nations like ours, unless we are prepared to make transformative measures. Now, we try to map the St. Lucia healthcare delivery system. And I want you to really pay attention to this slide. The first top looks at the patients, all the different patients that you treat, that receive services, those who are employed, unemployed, employed with insurance, retired, non-residents, people like myself that come out from out of the country and get sick and need care. Secondly is who pays for it? The government, your out-of-pocket that you pay, the private insurance, NIC, others, international insurance and travel insurance companies. That's all the different participants in payments. The last part is who are your providers? Public, private, hospitals, labs, pharmacy, all the different providers that provide healthcare. But I want you to look at something really, really closely. Is the lines, those red lines, that establish the relationship between the patients, the payer, and the providers of healthcare. A lot of lines. I get dizzy looking at it. I don't know about you. What that represents is a complex morass of relationships that's totally inefficient and high cost. So that these red lines here spells inefficiency, redundancy, high cost, poor service. So one of the first things we have to do in the entire system is transform this to something a lot more simple, to where we have the public and private working together. We don't have all those moving relationships. And until you do that to simplify the healthcare system, impossible to transform and to have a system that works. And by the way, I already note this. 12.2% of St. Lucians currently have health insurance. Not enough to sustain. Here's another challenge. We don't know what the cost is for healthcare services that we pay for. The government produces a budget, but we have no ability to say what an X-ray costs, right? This is a study that one of the Caribbean islands did to try and understand cost. So for minor surgery, they looked at the gauze, they looked at the medications, the doctor, the person who cleans the floor, any contribution that's made to participation. And they found for minor surgery, it's an estimated 6,000 EC dollars. Well, how is the hospital paying for this? The patient, from the fee schedule, is charged $270, and that's statutorily. And that's a fee schedule they had from 1958. Okay? Now, we haven't changed this since. That's gazetted in 1958, so it's the same fees. But the world has moved on. We're charging the same fees. From the budget, estimates that they got about $150. So now you have about $5,500 left to pay for that minor surgery. Of course, the hospital doesn't have a proper collection system to collect when foreigners come for services and others. So they don't have a way to recoup that. So here's what that means. Okay, this $5,500 here. Excessive wait times and long lines. Limited supplies. Sometimes you have to cancel surgery because you can't get the supplies that you need. Limited services. Limited equipment. Inability to hire and retain workers. Quality workers. Unhappy healthcare workers. And ultimately, you have an unhappy and unhealthy community. All because, one, we don't understand the cost. And because we don't understand the cost, there is no impetus to fix the problem of financial allocation. It sounds simple, but that's really what's going on. So here is the current patient journey. So if you don't have, if you're uninsured, here's what happens. You go to the public system, the government pays. Sometimes they collect in the public system also, depending on where you go. But the public system, because it's underfunded, they can't provide all the services you need. So what you got to do, you got to go to a private doctor. One of the ladies here was telling us a story that she went into the public system to get help for her blood pressure, which was extremely high. She had to wait so long that she got frustrated. And think about it, your pressure is already high, you're waiting all this long time, and you're not getting the service you need. So she decided to go to the private system. She got help. But guess what? The same doctor who was supposed to see her in the public system saw her in the private system. So the question you ask, why? Why couldn't she get help in the public system just like she was going to get help in the private system? You understand what I mean by silos? This is the real story about how healthcare is administered in the Caribbean. So we have to have a way of bringing the public and private system together in a way that's sensible. And here's the other problem. The lower line here shows incomplete medical records. What it means is that doctors are so busy, a record system is not always kept in an accurate manner that you could carry along that record so you avoid duplication. So let's suppose the public system did some tests. By the way, you got to carry that information to the private doctor to tell them what they did. But if you didn't have a piece of paper or you didn't have an electronic way of transferring it, and you may not, if you don't come from the healthcare industry, understand what the doctor is explaining, right? So you may either give the wrong information or not at all. And generally speaking, when that happens, the same test gets ordered. And guess what? You have a duplication of effort, you have an extra cost that you would not have otherwise have to pay if you were able to carry the records through the system. So this is largely paper-based, and paper-based increase costs.
10 minutes.
Now, this is an example of the patient journey with somebody that has insurance. But guess what? You still have a lot of out-of-pocket expenses. And what you have to do is, generally, you have to pay the doctor up front, okay, and then you go reimburse from the insurance company. You may not have the money right away to be able to pay for that services. So if you don't go and access the care. Well, does that help you out in any way? No. So we have a reimbursement system on the private side. A reimbursement system, not a payment system.
Right here.
The world. Okay? When you look at what has happened over the last 15, 20 years in the Caribbean, we have, and we can't only blame the government for that. We have to take the blame. The health system have to take the blame. The public, the private, all of us have a little culpability in this matter. Okay? It's not just the government. Okay? We all have that. And like I earlier pointed, all of us have some reason while we see it from our perspective. So what we've done is because of all of the complexity, because of the will that's required, political will on all of our parts to participate in this transformation, we've put a little bandage on it, what we call a poultice, with a festering sore underneath that we're not fixing. Okay, so what we're saying is, in order to transform and change the system, we have to make fundamental transformative change that's sustainable. We can't do a little fix that fix it for a half a year, the next year, fix it for now, and then we're back to where we start. But then the question comes, how much of us are willing to hit this head on and make the necessary sacrifice, and I say sacrifice, to change the system so it works better for every one of us? St. Lucia is in the best place that's ever been to fix this today. The question is, are we ready to make what the sacrifice that it requires to do this? And here's why. First, more than 50% of the St. Lucia population is under 50 years of age. And why is that so important? You're under 50, you're in the working class, right? You're in the contributory class. Now here's a challenge that we have in St. Lucia. Last year we had 1,400 live births. What that means is that we have negative population growth. And that means that we're not producing enough young people for the next generation, and that's getting less and less. So guys, let's keep having some babies now. Guys and gals, so ladies. So that the problem we're going to be faced with in the next 5 to 10 years is that we're going to flip to a consuming population. What that means, we're going to have more people turning 60, and those people are going to be getting sick. And therefore, you have less contribution, or people working to contribute to the system, and more people using the healthcare. So that's an avalanche that we're waiting for as we age. And guess what? We know what we have. As you get older, you're not covered. As you get sicker, you're not covered, and you lose your insurance benefits. Now here's the other reason why it's a good time to fix it. The whole Caribbean, including St. Lucia's economy, is thriving post-COVID. 7% GDP growth. Now people will debate that, but what I say is even 0.2% GDP growth in any nation is considered remarkable. In the Caribbean, we're enjoying this because of tourists, and we might have forgotten agriculture. Growing up, that was the economy I knew about, but still, hopefully we could bring that back, because that's also an important part of health promotions. 11% of the population is unemployed. And the debt to GDP ratio is 72%. Way better than places like Barbados, which is 124%. St. Lucia has one of the best debt to GDP ratio in the region, let alone around the world. So economically, we should be able to do this. Now, here's another reason why. I've been coming to St. Lucia at least a week a month. And I was telling the other group that every single time I drive that road from Viewfort to here, I look around, I do not see old cars. Seriously. All the cars are pretty new, maybe 3 years or less. So guess what? We buy car insurance, all of us, right? And then you look up on the hills and you see those mansions. In fact, when I was flying back a couple of times back, some foreign guy was sitting next to me and he said, "Man, this country is rich." I said, "Why do you think so?" He said, "Man, you see the houses these people live in?" Again, you look, there's the ambience of this affluence in our society, because we have beautiful homes, we have beautiful, not just the homes, but look at the environment, the ocean, everything looks great and peaceful. And guess what? We have insurance for our homes in case of insurance of a hurricane. Well, guess what? Do we have healthcare coverage in case we get sick, or kids get sick, or parents get sick? So I have to say this, as consumers, we also have a responsibility in this matter. And also to take good care of ourselves, and follow some of the health practices and preventative things that we are doing to help keep our nation healthy. Okay? So, our first solution to this is to, where I started, is to eliminate the silos whenever we possibly can. It's a big concept, but you eliminate silos by connecting them together and sharing information. A lot of us don't want to share the information we have, but we have to get into that mode in order to make things work. So, what is the winning strategy for UHC in St. Lucia? I gotta say it's simple, although there are complexities in changing it, but it's rather simple. And that is consolidation. Consolidation. If we consolidate, we achieve what we call collective bargaining. It means that you could buy things cheaper because you're buying it in bulk. Okay? The company that we run is called JIPA Network, Joint Independent Provider Association. Worked at Jackson Memorial for many, many years and the University of Miami. And one of my roles was to travel around the Caribbean and Latin America to help people get access to care in the US. And I had the opportunity of seeing what really happens in Caribbean healthcare. Build relationships with doctors, with institutions, with insurance companies, and with corporations that literally sponsor and pay for healthcare. So we've been able to get a good understanding of the challenges that people face. And what we realize, that, which is a network of doctors between these countries, facilitate the process so people could get access. And the way we did it is to consolidate. We got a bunch of doctors coming together, working with a bunch of hospitals, and we worked with every facet of the Caribbean society, from the private individual to the public system, to the private hospital, to the insurance companies, and we bundled these patients together and give them access through the organization we create. And we were able to offer healthcare services cheaper than just about anybody else because we bring volume to those institutions. It works. We started that in 2008. We really didn't get really active until 2012. And between 2012 and now, we've transferred over 6,500 patients with complex stuff. Burns, heart condition, strokes, all the catastrophic things that cost a lot of money to treat. That's what we help people do. And that's because we found an association of doctors referring patients to each other and hospitals that communicate. And we bundle the patients to be able to achieve this goal. So why can't we do this in St. Lucia? Okay, so what we say, in St. Lucia, the first thing we want to do is organize all the providers on the network. We call that an independent provider association. To be able to contract with the UHC authority, right, to provide the services through that entity. Okay? So that's the first reorganization we're talking about from a consolidation standpoint. The second is to find everybody and every entity that's responsible for paying for healthcare and bring them together. Okay? And we develop a model called SPARK, Stratified Pooled Risk Coverage. And I'm going to show you about that in a minute, how it will work. But the idea is, rather than each person for themselves, let's organize the payment system so it's structured. So think about this. If you have 10,000 people paying for an insurance policy, and one person in that group needs a bone marrow transplant that costs $250,000 or more, those 10,000 people don't have enough premiums to cover that. But if you have 1 million people paying the same premiums, they could cover a lot more than one person. That's what consolidation of financing is all about. Is bundling as much people as you possibly can, which leads to the other point here. We call this a strategy of called covered lives under management. The rich, the poor, everybody bundled together. Now here's the other reason why that works. It strengthens your medical institution. So if you have 10,000 people over here with really good health insurance, and those people could afford to have a heart procedure performed, and the private system develop a cardiac center of excellence, and only those 10,000 people could afford to use that facility. Of the 10,000, let's say 5% of them will use the system, and maybe 1 or 0.05% of them will have a cardiac condition. By the way, that's not enough patients to support a cardiac center with a interventional cardiologist, all the necessary equipment, the technician. So you don't have enough population to support that. But if we go to the 100,000, 184,000 people in St. Lucia, right? And we say everybody could come to that cardiac center. Guess what? You have more than enough people to support that center so it could be sustainable and be a center of excellence. I come from an institution which is public. It's called Jackson Memorial Hospital, about 1,500, close to 2,000 beds. Okay. And it's run by the Dade County. It's a government institution. And the doctors come from the University of Miami, which is a private institution, who I actually work for. And you can't tell the difference. I have my office in the Jackson Memorial system, but I'm a University of Miami doctor. And they work at all those relationships, something called an annual operating agreement. And in that system, it's one of the best in the world, not just for training, but for patient care. They offer just about everything, transplants, cancer care, everything. So you ask yourself, how could a county institution that's run by a government be able to achieve where a prince, a prime minister, the wealthiest people in the world gets cared for, and the poorest guy on the street that's homeless, all in the same place? How is that possible? Guess what they did? Exactly what I'm talking about, is consolidate, bringing together the private and public environment through operating agreements that allows this system to thrive and making it fair to everybody. And again, you don't just have wealthy people going here or there. They want to come to that place because it's good service. And it's set up in a way that they have the volume, they have the consolidated financing, and they look at it from a population standpoint. It works. So people always say, Dr. Ned is an example of something that works. That's one. Guess another place that does that? Your neighbor. Martinique. Martinique has the exact same system where you have government and then you have private insurance on top of it. And they work together. That's why they could sustain and support those advanced standards of care. So it's not all over. So what would success look like? I already pointed out all the challenges that we had. The first one I talked about was the benefit premium model of healthcare. All right? The benefit premium model of healthcare. That's the model that if you old and retired, you get excluded. If you have a pre-existent, you're excluded because it's benefit focused. So here's what we want to do. We want to shift this model to something called a care-centric model of healthcare, where everyone is included. And now that you consolidate this together and you build that institution that I just talked about, that not only take care of the wealthy, but takes care of everybody else and bring them together. But what you do is you have a system of navigating people through the system so they get care in the most appropriate and most cost-effective place. Okay. Yes, you want to go to a very expensive hospital, has a big name, but realize that a lot of services could be done outpatient. And there are facilities that don't have a big name but could perform some of the best services. What medical institution needs is volume and quality. So if you build a hospital and you have an expense with that hospital based on your employees and your costs, what we all know that a certain amount of patients and a certain amount of disease condition gets you to break even. After that, it's gravy on top. So if you get the hospital or the facility to critical mass by sending them enough patients where they become self-sustainable, every additional patient that you add to that is gravy. That's what we need to do with our institution, so we get them in a stable place. You do this by having, not discriminating with people, but bringing all comers, but setting up a system where you could coordinate the care, where it's efficient, it's low cost, you don't have all those red lines in terms of relationship that I just showed you. So that's the first. The second, if you think that we just rely on the government tax-paying system or the employers and the employees to pay for this, it's not going to work, because we know the problems already. We got to get those people in the informal economy who don't pay taxes to participate. We don't want to exclude the insurance company. Most of the national health insurance UHC programs in the Caribbean, if not all of them, are based on pure taxes, either of the employees or from a consolidated fund, and didn't include the insurance and private sector. All those countries who did that hurt the insurance sector, and they lost a very important part of the contribution to healthcare. Everybody thinks that the insurance company are just out there making money. Well, they're businesses, they make money, but they play a very important role in balancing the financing of healthcare if they're included. And if we include them, we have to put them in a way that it makes perfect sense. When and if we have a system of paying for healthcare, guess what happens? You bring investments. People feel secure. They're going to build cardiac centers, stroke centers, rehabilitation centers, because they know that there's a way to pay for it. But if you don't have a way to pay for it, you're not going to build and develop your healthcare system. You're also going to keep your employees, and you're not going to have a brain drain, you have a brain gain. Why? Because people, you have a way to pay for it, people want to come back. And right now, the system we have is not merit-based. It's based mainly on seniority. Merit means that if I'm qualified, you got to pay me what I'm qualified for. If not, I'm going to leave. So we have to switch our methods of compensation in this regard. Other point is, we got to have a way where out-of-pocket expenses got to drop that to a low level. We got to go from the 37 cents down to a 5 or 10 cents, so that all of us are able to share that extra out-of-pocket expense across the whole country. So everybody's paying a little bit of that, not just you as an individual. When you're in that top 5% of people that have a catastrophic or complex condition, you are paying a big chunk. But if you spread it across the population and everybody pays a little bit, it works. Just like you do with car insurance and homeowners insurance. Everybody pays a little bit. Okay. So we have to work with the informal sector to make sure they participate. And how are we going to do that? We'll have an answer in a minute. So let's look at the new system of patient flow, how patient flows through the system. So you as a citizen come into the system, and what we're going to have here, we recommend you have a primary provider. It could be the ER, it could be your primary care office. That's your starting point. We call that a gatekeeper system. What we mean by that is that you don't want to go to one doctor and 1 minute, I don't like the guy's head, so I'm a person's head, so I'm going to the next person. We have to build relationships between your doctor and you. And by the way, it's not just the doctor. You have nurses, you have nurse practitioners, you have others that could participate in that experience. All right, so now it's a group. And we are going to sit review your situation. First of all, we're going to register you in the system. And we're going to use create an electronic digital record. So it's not just a piece of paper. And that record could be passed on to the next person for the levels of efficiency, to reduce duplication of effort, and your safety and as a patient and quality. For this to if that doesn't happen, we can't transform the system. We need to use digital records. This system uses a form of payment for that doctor, not just to take care of you, but to coordinate your care. Right? I talked about a care management system, shifting from a premium benefits-based system to a care coordination system. That's where it starts. So every month, we're going to pay the doctor a fixed amount per head. It's called capitation. All right? That doctor, say they get $10. We're going to incentivize them to do the right thing. So if that doctor takes on you as a patient and we pay them $10 a month, we do a whole back of $3. And we come back at the end of the year and we say, okay, or the end of a quarter, or the end of 6 months, Doc, if you did the right thing, we're going to pay you those $3 back. Okay, and here's how it works. The doctor has a computer system in his office and have someone in there helping create these electronic records, dictating, typing what he says, voice, whatever is in that office. But that record could be transferred electronically, like even when they file for a claim for payment, guess what? We're going to give the doctor 50 cents or $1 back. We just incentivize them to use electronic medical records. So it's an incentive. I'm not forcing anybody to do anything. If you don't want to participate, you get paid less. Now here's how you improve quality. There's something called evidence-based medical care. Right? For example, right now, medicine is so structured. It's just like when you buy a new car and they tell you at 6,000 miles you have to do this, at 10,000 miles you need an oil change, at 20,000 miles you could do this. Our bodies are just like that now. We have structured times, structured processes when you're a baby, when you're a teenager, when you are an adult, childbearing years, when you get old, what you're supposed to do with your blood pressure, with the way you live. All of that is well defined and tested in healthcare. Unfortunately, in the Caribbean, we don't operate under those terms. You know, when your PSA as an older man has to be checked, when you're risk for cervical and cancer and colon cancer, whether you should have certain tests to check for colon cancer, or breast cancer, especially if you have a family history, or hypertension. All those things are all defined in healthcare really, really well. And if we don't do that, we put ourselves at risk, okay, for major catastrophic healthcare events. This is what Doc is doing over here from a prevention, so we don't get those catastrophic events down the road. So we're going to incentivize that doctor to make sure that they perform those tests when they're supposed to. And we're going to pay them a little bit more to do that. We call it pay for performance. Under the current UHC, we call it performance-based financing. Okay, it's the same thing. So the idea is that you compensate, and let me tell you, we also do that. You have a question? We're going to answer that question in a few seconds. Well, minutes. So the real idea is that if you provide the incentives, people are going to do what they're supposed to. And in one full swoop, you'll transform healthcare. Because people are compensated to do that. Now, let's talk about the consumers. How do we get the consumers to participate? Okay, we don't like people just crowding up the emergency room because that's a higher cost. It's inefficient. When you need to go, we need to make sure you go for the right reason. Okay, so we want the doctor to take more responsibility. So when you call them, they're more receptive, so they avoid that emergency room visit, which is expensive, and it demands extra resources, more nurses, It's crowded. Everybody goes in there. Some people go for simple things. And all of us get upset that, oh my God, we have no beds. The emergency room is full. Well, think about what you're there for. Are you there for something that's appropriate? But you might be because you don't have access to after-hours healthcare. So, again, the gatekeeper system solves that problem. Part of what the gatekeeper is going to do is to decide, help you decide what's the best place to go and where to go, because now we have a knowledge-based system that keeps track of every single provider in the system, what they do, what's their availability, and so forth. And when you understand that, you could manage the risk. Okay, now you come to UHC, authority. Now, this body is going to be separate from the Ministry of Health. It's going to be run as a statutory body similar to NIC. That's our recommendation. And here's the reason why. You need a group of professional people to be on the board that understands how healthcare and insurance and financing work. And you also need an executive team that knows how to carry on the mission of this organization. So now we are consolidating all of the claims and the requests for payment through a contracted mechanism with all the providers in the UHC. Here's what's going to also happen. All of the payers, the government, the insurance companies, and other sources of payment, all right, going to be communicating with the UHC. After the claims have been adjudicated as far as who should pay what, the UHC would have the responsibility of collecting the money from those entities and paying the providers. Now we just changed the system from a reimbursement system to a payment system. So as a consumer, you're protected. Instead of one doctor or one person going to the insurance company to get payments come back to them, the UHC as a body is going to be working to get reimbursement from an insurance company. And those are going to be governed by very strictly run contracts that stipulates what benefits are being paid for. So that system has to have a computer that has the ability to adjudicate that claim that's been made for payment. So as a consumer, you don't have to go to the doctor or go to the hospital and say, okay, I have to pay before I get services. Now, we're still going to have some co-pays, but that's going to be small amount. We're still going to have some deductibles and things like that, but it's not something that's going to break the bank, because that's part of how we're going to pay for things. And those system reduces it to a small enough level that everybody that receives health care could pay a little bit. And of course, the people that can't, we're going to have means testing to be able to help them avoid paying. Now, this is what we have now. And all of we're talking 20% admin costs or more to keep the system going, okay? With all these lines in every direction. This is what we're going to have after UHC is organized. It's a simple system. You don't see all these red arrows. You have a central place where all the data comes. Everybody knows where they are in the system. A simple system of payment, request at both sides, and payment move. Data moves, patients move. That's called a care-centric model of healthcare. That's the fundamental change that we need to make in St. Lucia to make this work. So in the middle, you have a data center operations, you have a third-party administration, you have a group of contracted providers domestically and internationally with pre-arranged pricing where you could collectively bargain, right? Where you have group purchasing, where you could buy through a bigger group than what you have. If you only have, one doctor doing 10 pacemakers in a year versus a doctor that's doing 1,000, the guy who's doing one is going to be paying a lot more for that pacemaker compared to the guy that's doing 1,000. So now you could bundle all those together and purchase. That's called group purchasing. That's a very common exercise in healthcare financing that's utilized to reduce cost and improve quality. St. Lucia would be in a great place to make that such a difference. Now, to do that, we have to make some more sacrifice. We have to implement a communication system, okay? We need the insurance management system that takes all those benefits and has the ability to adjudicate the payments, whether it comes from the government, the insurance company, or the individual. We have to have a provider management system in the hospital, in doctor's office that talk to each other and collects information on price. It's able to generate a claim. It's able to do a P&L, a profit and loss, so we know what something costs and how much we get paid for, so we can balance the equation on both sides. So we could run those institutions in a sensible way, just like you would run any company, okay? And then you need the piece that connects the whole system together. It's called EDI, or electronic data interchange. In addition, you could transfer funds through this mechanism. You could make requests for things like, is the person eligible? Did they use their benefits? All in real time without even picking up the phone, right? So you need a system like that to be efficient. By the way, those systems are available, but it will take a massive cultural shift with change management across the entire healthcare delivery system to achieve this goal. And it's possible under UHC to do this and do it now. Now, just a minute, I want to tell you about Healthcare Financing 101. Okay? Because this is the heart of what we're talking about. I'm a doctor, I'm not a healthcare financing expert, but I've been around it long enough to understand it and be able to explain it. So healthcare financing has 4 dimensions. Okay? The first one we've been talking about. This is the highest level of healthcare financing dimension. And that's where you consolidate all the dollars. Money from the insurance company, money from the government, money from international insurance companies, from the NIC, you consolidate and you say, right now St. Lucia spends about $191 million between the Ministry of Health Operations and providing care services through the public system. Okay? One of the things we did in other Caribbean nations is to see how much money was available in the healthcare system. And we did this in Grenada, for example. The government spent $115 million, and we found almost $300 million in the healthcare system. Okay, because other people are going overseas for care, getting care and paid for, and it's not accounted for, because all we look at is the government system. We don't see the others. So I'll guarantee you, of that $191 million spent, there's a lot more being spent. Right? The World Bank recommends 5% of GDP. And 5% of GDP is about $350 million. There is $350 million in St. Lucia's healthcare delivery system. So we have enough money here. Whether or not we could access it and put it into that pool is another question. So I tell you that when we look at the highest dimension, there is enough money there. Now, how much comes from the consolidated fund? We could negotiate and add to this to give it more security. Depends on a lot of factors, which we're discussing with the government at this point. Second level is what we call, or the second dimension is what we call the population dimension of healthcare financing. How much of that 250 to 350 million, because we think it could be a range, right, is allocated to each individual man, woman, and child. Here we think it's about $158 to $160 per person per month. That's from our own calculations. That number could go a little higher or a little lower. But we know that. Okay? Those numbers give us the ability to have a balance in our calculations, so that we could create a secure environment actuarially to make sure that the system works. But we need data in the system to check our assumptions and to ensure that our assumptions are right. And we also need a buffer, plus or minus, if we don't come out on the dot, one way or the other, that we're able to make sure that the system is secure. So we need that number and that second level of financing. The third level of financing, which is on the third dimension, is what we call the clinical level. That is, all that money that we have in there, what do we do with it? How much we give to the pharmacy, how much we give to the labs, how much we give to the private doctor, how much we do give to the hospital, how we allocate those dollars. That's very important. And we have to balance it. If we give too much to one system and not enough to the other, we create chaos. So that's an important part of the system. And the number one dimension is what we call the granular procedure unit level. That is what you pay for each unit of care that's provided. For an x-ray, for a doctor visit, for an injection. What do we pay for each of those? That's where we're struggling. We have to have that number in order to make sure the other dimensions work. And to do that, we have to have a healthcare finance system set up in the hospital, in the doctor's office, have price lists, have standardized way of pricing healthcare so it's predictable. So all of that we have to do. It's a lot, but it's doable. Now, the main issue, and the question was asked by the young lady over here, how are we going to pay for this? And there is your answer. The first thing we have to do is to reorganize capital, that's all the money, in a consolidated way. And when we do that, we reorganize the risk. When we say risk, it means that what's your risk as a person having a major illness and not be able to pay for it? We have to reorganize that risk. And we have to spread that risk across the entire population. So if you have something that costs $50,000, we want everybody in the population to pay a little bit. The government, the insurance company, so that risk of you paying 37 cents on every dollar is eliminated. Doc, in an opening statement, talked about that. How do we reduce out-of-pocket expense that's causing poverty, that's causing people in their retirement years to use all their savings for one medical illness? So the way we do this is by this structure. We call this SPOT, Stratified Pool Risk Coverage. So we stratify it and we pool the dollars together. So we take the money that's currently in the system that the government is paying and we put it at the first tier. And that goes up to a maximum dollar. So every care that falls, and that's mainly primary care, but you can have some secondary and even some tertiary care going into that bucket. So in that bucket, whether you go to the private hospital or the public hospital, once it falls under that dollar amount, the government pays for it. Now we achieve something called universal health care. We're saying that the dollars that the government has in its coffers, we are going to use that to cover the level of care that the government could afford to pay. Hopefully we could increase that. So let's say a medical bill is $100,000. The government will pay the first $10,000. Okay? Now, some people are going to use $1, some people are going to use $0, and others are going to go up to the maximum. When you add that with all the people, which is about 20% of the population that would access healthcare in any 1 year, you come up with 65% of the entire first dimension, entire amount of dollars that the government would spend on healthcare. It's in this category. Okay? Now, we have some further calculations to do to protect this fund right here, to make sure that there's enough to go around. The second tier is for those people who have health insurance and those people who have the ability to pay. Okay? They'll pick up about 25% of that. And that's going to cover a lot of your secondary care, more advanced stuff. Now, what we just did for the insurance company, we took them out of a headache. They don't like this. They don't like you to come to their office after they have a primary care visit for $200, $300 to see how much you could get back. We just eliminated that. So they don't have that cost anymore. They don't have the cost to pay you for that, and they don't have the cost to administer it. So that's going to cut down on all the administration, and they should be able to lower the premiums so that more people could afford to buy insurance. All right? So the idea is, by protecting the insurance company here, we want them in return to insure more people. And there are a lot of people that say, I ain't buying insurance because I'm not going to get back the money when I'm sick. So I might as well go and pay for it for myself. And that's the informal sector. If we do that, more people in the informal sector, those people that are not contributing heavily to taxes and so forth, would buy health insurance. And the other thing we're going to do, we're going to put co-pays and deductibles. So if you could afford to pay for insurance, we're going to say, and you don't pay for it, you only can get your health care in the public system. So that we don't have a massive rush from public to private. And if you're going to go to the private, then you have to pay a large copay and deductible unless that care is authorized. Why are we doing that? It's because we want to protect the health systems on both sides. And we want to make sure that both sides are treated fairly. By the way, the hospital is going to be able to bill, the public system is going to be able to bill the insurance company and get paid. And the private health system is going to be able to bill the government and get paid. So the problem of that doctor that we talked about, right, not being able to provide the same care in the public system, right, and has to run over to their office and provide the system over there where the consumer has to pay, that's gone by having this tiered system. I see somebody's brow. Is that clear or no? Yeah. You're thinking, okay. A lot of reflection here. Okay. Now, once we have a system like that, it allows us to collect data in a central place. Because to get paid, everybody got to send their information to the UHC. Now we have information on cost, we have information on how much, what we call utilization, how much of a certain procedure is used in the country, what kind of diseases people have, and we could know our risk. And we can know where high-cost care we have in the society, because we have all that information. We now could go to a reinsurance company and say, we're going to pay you a premium for that small 5% of the population that's going to access catastrophic care, maybe in excess of $50,000, and buy a policy. So whenever that happened and we go over that month, they would provide the service and pay for it. But we have to pay them a premium. Other opportunities, we could bundle those groups of patients in catastrophic, and the government and the private sector could just have an institution that takes care of those people, and after the limits are gone, that the insurance company doesn't have the risk. And that protects them. Because what they're concerned about is high cost procedures that makes their premiums unpredictable. So every year they have to keep increasing it. We just protect them on both ends. So now insurance becomes sustainable. You'll have more people signing up and more dollars coming into the system because you just strengthened your insurance marketplace. By the way, they're going to compete for it. And you, the consumer, is going to drive which companies win. Because they're going to be allowed to offer a basic set of benefits, and anything that they want to offer over and above that, obviously you'll have to pay a little bit more for the premiums, but it's worth it. Because if you could save yourself a major catastrophic dollars spending ticket from your pocket, you might as well pay for a little bit all along and keep yourself secure. So this is the system we recommend to the government and the infrastructure that we support and could potentially provide to implement this. Now, in order to get this through, we have to focus UHC in a project management manner. So we have to pass legislation. We have to work with the financial ecosystem to get all the data we need and come up with the assumptions so that people feel confident, including the government and others. We have to implement the IT systems, working with what you currently have and new systems that you don't have. We have to set up a governance systems through a statutory body to make this work. And of course, we have to do project management to keep this running on time. So we have a project plan that we put together starting in the last quarter when we got the contract, and we did a lot of work already, enough that we have a policy document, we have project plans, we have IT plans, data collection systems, and all of those already put together. Now we're in Q1. We're working with the AG and the Parliament and the cabinet to be able to get legislation through. We're now in the stage of having these stakeholder conferences where you get to give your input. Now, I don't know if you all got a copy of the policy yet, but if you didn't, we'll make sure you receive it. We'll make sure you put your emails on all of those. We want your feedback because the policies have specifically all of those things I talked about and more that has to be changed and put in place legislatively. And we want to know how much those things impact on your organization in terms of that. So as this system outlines, stepwise, every quarter what's going to be done. Okay? Again, quarter 3, quarter 4, and then the first quarter of 2026, we plan to have some kind of launch, a soft launch of this program moving forward. So we need your help. First, we need your help to read it, understand it, make supportive and critical comments back to us. And we want you to be involved. We want you to go online through social media and communicate to us. We want you to attend our meetings. We want you to talk to people in your neighborhood, talk to the people in the credit union, your leadership. Give us opportunity to present again and again so that something that's really, really complicated, we will make it simple for the man in the street to understand and understand why and if they're going to participate. The government has made a commitment to make this, to bring this thing forward, and they're putting a lot of political will and energy behind this at this point. So this is our break. Let's run for it. This is nation building, in my opinion. It has nothing to do with political affiliation. It is how we change the narrative to affect us and our healthcare. Healthcare is always in the news in St. Lucia. Not just St. Lucia, in all the Caribbean islands. And it's an important part of our current and future lifestyle. So, just a bit on the policy, we have 8 areas. The financial ecosystem, and the financial ecosystem doesn't only address how we pay for healthcare, but it also addresses how we finance the development of our healthcare institutions and how we work with international organizations, non-profits, public and private partnerships, how participants in the private sector could help implement this and how they could help support the funding of it across the way, because everyone stands to benefit. We have a program that we suggest be included called the Health Savings Account. And for the credit union, in fact, I've discussed that with other credit union movements, and they love the concept. All right? For things like copay, for services that may not be covered, certain dental procedures, plastic surgery procedures, things that generally most plans don't cover, right? Or to help you with your copay, or something that the government or the UHC can't cover, an employer could put and deposit a certain amount of money into an account. You could do it yourself. A family member or friend from overseas could do that, so that you save those dollars for a rainy day when you need health care. You could use it. Generally, health savings accounts are tax deductible, all right, if the money is used for health care. So this is, the credit union movement have said this to me. Now, one of the major reasons why they give loans, other than for homes and cars, is for people seeking health care. And guess what? This is the biggest risk time for those individuals, because if they have a terminal condition that they don't survive, they can't work to pay back for it. And that's a challenge. So we want you all to be involved, and we believe for the credit union, you know, that's an amazing opportunity to encourage savings and participate in healthcare financing, because we feel that just that alone could, over time, could inject $8 to $20 million in savings between banks, credit unions, financial institutions for this. And if we put this in place, it's another way of helping to offset the cost. So we want you all to be involved. We feel that's very important. Many, many countries have used that as a mechanism of financing healthcare. So I'm going to stop now, and I'm going to open the floor for questions that you might have. I know it's a lot of information we throw at you, but we think it's critically important that we hear from you and you give your opinion. I know the young lady over here had a question, so hopefully we answered your question. You have any further comments? Okay, good. Okay, the young man over here, just say who you with, and then we could, you could ask.
So, Donald Bob from the Forces Credit Union, and I'm happy to hear from a doctor that I'm a young man. Thanks for the presentation, but as usual, do I need that? Is for that? Do I need that, or can I just speak loudly? Okay. To me, we continue to fail to address one of the biggest elephants in the room when we speak of healthcare and so on, including UHC, and that is the price of healthcare. And I say price because I want to juxtapose that against the actual cost of producing healthcare. We have fallen into this thing that healthcare is expensive, and it continues to be expensive, and we continue to accept that. In the absence of having empirical evidence, I will use the word perception. There's a perception that the price of healthcare far outweighs the cost of providing that service. In other words, healthcare providers, individuals and organizations are no longer in this thing primarily and mainly to provide healthcare, but really to maximize profits. And so we find ourselves, or we believe that we're paying a lot more for healthcare than we should be paying. And to me, we continue never to address that elephant in the room, which impacts the provision of universal healthcare. What are we doing? Have we really studied the cost of providing those healthcare services vis-a-vis the price that we as individuals pay, or even governments pay for it? And I'll give you an example. Not too long ago, well, several years ago, I had a motorcycle accident. I broke my hand. I was sent to a private healthcare provider, a public, sorry. And I was told that it was a severe injury that required immediate surgery to reconstruct the bone and so on. It was a Wednesday, but I had to come back the Friday to do it. I didn't survive. One night, my wife saw me in tremendous pain, took me to a public provider, a private healthcare center. The cost that was given to me at the public healthcare provider was about $6,000. When I went to the private healthcare provider, who was able to do it for me immediately, I had to pay $24,000 for that. And that's several years ago. So what are we doing to address that elephant in the room that will impact significantly the success and the sustainability of universal healthcare?
This is a very powerful question. You wanted to say something? Yeah. I'll ask Hassan to comment, and I'll comment.
So I think it's important to recognize, and I'm glad you bring up the elephant in the room. It's perspective.
National Plant of St. Lucia.
So understanding and recognizing that there are multiple perspectives and aspects to this. And the first being is the lack of information. So data data is king in this sense.
So
It's
very
so
blend like
important.
a potato as well. Iron, you was a vegetable. Lots of iron.
So
when it was yellow, the iron eliminates into potassium as a fruit. But when green fruit,
let's see, is that
yellow? Of course, the national, we have two of those. Rose
try again. Okay. Sorry about that, guys. Okay, perfect. Can you hear me now? Awesome. So, one of the critical pieces of recognizing this is that when you look at healthcare, and anytime that someone walks into a doctor's office, this is a common thing that we hear of people that have to seek care with a physician. There's this perception that they make all this money, they have to be greedy, that they want more, or that the hospital wants more. But the reality is that there are two sides to this story, okay? And the side that we're trying to make sure that you understand in terms of the global picture of the elephant, so going back to that idea of one person has the tusk of the elephant, the other has the tail, is recognizing that when it comes to the cost of healthcare, we largely don't have a good understanding of that in the Caribbean. And unfortunately, the reality is that it costs. It may not necessarily always just cost in terms of what comes out of your pocket, but we pay for it no matter how we look at it, even in the public system. I'll give you an example of this. And if we go back to that slide, Dr. Ned, which I think is a good one to go back to, the average cost of a minor procedure, right? We know that on average, for most of the Caribbean, they're only getting about $500 towards a $6,000 EC dollar procedure. How are you paying for that? You're paying for it with the wait times. You're paying for it with the fact that you're not able to retain physicians that are fairly compensated for the work that they do. So are you paying for it? You're still paying for it in the public system. That's the first thing that I want to make sure that's clear in terms of that, or even in terms of supplies. And we see this all the time. A facility can't make an informed decision about what they purchase and how they purchase it if they don't have the information. How much gauze do you need on average for a medical procedure? How much saline? How much medical supplies as a whole? And we see this all the time. They'll have a storage room full of gauze and they run out of saline and gloves, right? And that's because they use a budget to establish how much they buy in the beginning of the year. And then throughout the year, they don't have sufficient to actually meet the needs based on data that informs how they make their financial choices as an institution. So this is where understanding the cost of care is so important. We're not saying that we have the full understanding of that. We know that there's been some studies on elements of this, but as you start to collect data in the first year and the second year of having a comprehensive IT system, it allows you then to make more informed decisions, to then purchase the right things at the right time, and then to also fairly distribute the funds that are being allocated towards those services. So that's one of the discrepancies that unfortunately the public system has to face, but also that the private system sometimes gets a bad rap for in the midst of that. And I'm not saying that it's perfect. I'm not saying, I can't even speak for the intentions of different people when it comes to that. But the reality is that there's bigger things that are part of that mechanism that often causes challenge. And the second thing that I will say, and this is a common thing that we hear from a provider's perspective, is being fairly compensated for their expertise and knowledge. The reality is the reason you have a brain drain throughout the Caribbean in terms of people leaving, whether that's skilled nurses or skilled providers, skilled pharmacists, skilled physical therapists, and all the other support staff for hospitals and facilities, is because they are having they're getting fairly compensated in other countries to be able to do it. You guys train amazing nurses. You train amazing physicians, people that have such great experience and can contribute back to your country. But the reality is, if they see in Bahamas and they see in the US and they see in the UK that for the same set of services that they could give right here, they get a bigger paycheck and they're able to support their families in a different way, it's hard to keep them here. So Dr. Eugene gives another example that I think is always a helpful one from a nursing perspective. When a nurse knows that they need 5 nurses to really manage the floor, and they walk in every day to 2 and only 3, but the same amount of work that's there, it makes it really challenging to do your job on a day-to-day basis. So these are the things that when you have information that informs the cost of care, that gives you the supplies that are necessary to give people the level of service that they need, that allows you to distribute the time and the work more effectively, it makes it easier then to manage. But the key here is when we're talking about the distribution of that cost and understanding of it, is that we're not saying that as a result of increasing the cost of elements of care based on how it actually costs the system, we're talking about changing the distribution of who pays for it. Right now, and I think Dr. Ned mentions this, 37 cents of every dollar comes out of your pocket. 37 cents of every dollar towards healthcare comes out of your pocket. And we're talking about shifting that percentage, right? We're talking about finding ways to have payers participate in distributing that cost amongst the population so it's not a burden to each individual. Does that make sense or answer?
Let me take another stab at one part of your question. And Kassan is right with what you just addressed. I want to just take a different slant to you. I give you the example of having to purchase, one doctor, he only does 10 pacemakers a year, and he's buying pacemakers. And then the guy over here that does 1,000, and he's buying 1,000. The guy that's purchasing one pacemaker is paying more for it. And of course, he's supported in a system that's not economically sensible. So basically, he has to pay for the staff, and he's not generating enough money to cover the service that they're rendering. So as a result, they're forced to jack the price up. Now, if you think about it, the public system is subsidized, but the private system isn't. I'm not trying to give an excuse for the private system, because a lot of times the private system you're paying not just for you, but you're paying for the tourists that came and got care for free. You're paying for, pricing is a very complex thing in healthcare. What I said before is healthcare works when you reach critical mass. If you build your institution to have 10 patients a month and you have 5, you're losing money. All right? If you build it to have 10 patients, cover your overhead, and you have 15, you're making money. So part of healthcare, just like any other business, it has this, and one of the problems you have in healthcare, you have ups and downs, different seasons and all that, and you have to, in a financing model, level this off. So the consumers are affected by a phenomenon that they have no control of. Second problem, a lot of drugs, a lot of medications come from the US, okay? And they have something called patent laws. So a pharmaceutical company that comes up with a new drug, right, have, I think, 23 years to maintain that patent when nobody else could produce it. And therefore, if they're the only person producing, they have the ability to set whatever price they want, because you have no other place to go for it. And so those laws, while they make the pharmaceutical company rich, they also support the investors and the people who put money in the pension plan. And that's something I'm totally, if you go to Europe, it's a whole different system. All right, they still have patent laws, but the prices are not as high. So because of where we're located and where we get our medications from, and of course, those medications have higher quality, higher standards, lots of overhead. One of the things you pay for healthcare is quality and safety. Because there are a lot of people that you don't see other than the doctor and the nurse that are working in the system that needs to be compensated. And that raises the price. But it ensures that when you go, if you have safety features, that could add 15% to your overhead costs for any particular procedure that you perform. So we're not justifying the fact that there are price gouging going on in healthcare, and it's happening every single day. Some of it, some of those increased price are justifiable, but others of it is way beyond what we should have. That's why when you have a UHC and you have all that data coming in, you can see, oh, the guy down here, when you have a contract, the doctor can put whatever price they want, but that's what we're paying. And part of the contract that UHC will do will protect the consumer, because it'll dictate, we're paying this much of dollars for this, and if there's a copay, it's $5. And the providers can't go charge more than that. We give them opportunities. So you have to protect the doctor and you have to protect the consumer. In UHC, because you bundle and you consolidate, you avoid some of those problems that industry face where you don't have enough volume to make it work. That's why UHC is a consolidated model. And only when you do this, you're going to be able to control price. People go abroad. Yes. I agree. But you know what the problem is? The doctors know that there's not enough people in society to even afford it at a reasonable price. So what they're saying is, I'm just telling you the two sides to this. Now, if something that everybody has, it's easier to price. See, the law of supply and demand is a principle in economics that everybody knows about. The more of something you have is the less it should cost. That's really what's at work here. But sometimes in healthcare we cheat because we have protections. Think about it. If you only have one specialist in the country, okay, and then, you know, there are some specialists like hematology, neurosurgery, it's really hard, neurology, like in my specialty. In the US, it's hard to find, I train doctors too. Even those guys that are trained make more money than us, than me that's been around for a while. Because they're competitive, they could move here, move there. And if somebody needs you bad enough, they're gonna pay the extra money. So supply and demand also applies here. So healthcare financing and economics, the way you protect yourself is to consolidate. If you have a silo, you can't protect yourself and prices could be all over the place. And the first place to start in healthcare price controlling to protect the consumer is through UHC and through consolidation.
I just wanted to add one thing.
Yeah.
I understand where your situation, because sometimes you want to do you have to get some degree of treatment or something, and then when you go to the public sector, it takes a long time, because the volume, and therefore you have to wait a long period of time versus the private sector. But the nice thing about UHC, it involves the private sector, and therefore it increases accessibility. That's one of the things I really want you to know. And also it gives you, it allows you to negotiate prices so that you don't have this large disparity in prices as well. And UHC allows that. Let me give you a simple example. Not the broken hand. I'm sorry about the broken hand. Okay? I want to tell you, for instance, we wanted to do the relaunching of men's clinic and realized we had an issue where some of the wellness centers were not able at that particular point to be able to relaunch the men's clinic that we want in the community. But what we said, we realized the areas that were being affected would have been our region 8A and 8B under Ministry of Health, which is Castries Central and its environs. That's very important, that's the city. So we decided, let us bring in the private sector. And that is why we actually involve Medical Imaging Inc., and they provide all the services. They have physicians, they have labs, they have imaging studies, and it works out well. So instead of telling the patients, we can't give you the service because the public service is unable to give you the service at this particular point, we would not want to stop or disadvantage the patients. So we decided to bring in the private sector, and it's been working really well. So we have started using the private sector. So your issue of waiting for a long time, hopefully bringing the private sector on board under UHC will allow us to have more avenues, more accessibility, and decrease waiting time for services. Yeah?
If you have your private insurance and UHC comes in, what happens? Okay, great question.
So the question is, if you have your private insurance and UHC comes in, what happens? So one of the slides I showed, I'll go back to that one, right here. So what happens is, so UHC comes into play. Any place you go, the public sector, the private sector, for the first set of dollars that you pay up to a maximum dollar amount, the government picks it up. Whether you're poor, you're rich, whether you have insurance, don't have insurance. Now for you that have insurance, once that limit is reached, UHC is going to send the balance of that bill up to a maximum amount to your insurance, and they'll pay back UHC, not you. Your premiums actually is more likely to drop. And here's why. What you're paying for right now is all those 3 layers. Now you're only paying for this one. Right? And on top of that, all the administrative costs that the insurance encounter to process all these little claims for $50, $500. For them, that's little claims. That's administrative costs. That's a lot of money. Imagine, you see the doctor. You have to just think about your time. You have to make sure the doctor fills out the paper, write something. They get frustrated. They don't even like doing that. You have to go back and pick it up. When you go, it's not ready. Come tomorrow. You'll get it. And they don't fax it. They don't send it email. You have to show up and pick it up yourself. Just think about your time. Then you prepare it, and you send it to the insurance company, and God knows when they're going to be able to handle it with a stack of paper sitting there with all these people trying to process. And now they have to go and check all your benefits and say, oh, this one, it's $500. We only can pay, we could only pay
Why?
$50.
Yeah.
Oh, yeah.
The Eastern
No, it's right on this. Right. Good. Yeah, that's it.
You're right.
Hopefully that solves it.
And currency Eastern Caribbean. 2.5 Eastern Caribbean to €1. 2.5 Eastern Caribbean to $1 US. As we slowly make our way towards the main highway, what beautiful island, sunny island, Saint. Announce Lucia. Celebrate other countries as well, like Spain, Italy, Denmark, Finland.
Testing. Okay, so let's try that. So let's hear you verbalize your question. Yeah, you did.
Yeah, so I asked here,
hold on a second. You want to get that on? I think it got messed up.
Yeah, so with the UHC in place and Tier 1 now being taken care of by the government, and it should affect my premium. It should naturally, right?
Correct. Again, you have market forces, and why I started to answer the question when we were interrupted is that because the government is picking up this, that really saves the government admin cost and having to pay for a lot of service. I'm sorry, it saves the insurance, having to pay for a lot of those services. So the premiums should drop, and more people should be able to afford to buy insurance for that level of coverage. So we want the insurance to stay involved, and hopefully they'll give you more attractive products because of the fact that they're now having that opportunity to be covered. That makes sense? Okay. Any other questions? Okay, we have another question over here. I think you might be in front of the camera. Yeah, that's okay. Yeah, okay. Sorry.
My question is, will all citizens automatically be placed under the UHC, and at what point will they be entered into the digital system that you spoke about earlier on?
Great question, by the way. So part of what we have to, what we're working on right now is a system of registration. You qualify.
Back light and come back, okay? Yeah. Wait.
Yeah.
6 years.
Okay. So the way it works is that you have to have a do it really smart. Do a digital registration as much as we can. Everybody has a cell phone. Everybody has an iPhone. We might be able to use that. Again, we could do something similar to how the census work, but that's costly. We also have brokers. We have insurance companies. We have employers. We have the NIC. So the idea is let's use all the resources we can to get people registered in a way that is not going to break the bank. We have to be conservative. This thing is very costly to do. The point is that we just got to spread the word, get everybody involved, create an environment. You guys are in the union. To help registration is you have people with bank accounts, credit union accounts that provides for services. You could join the party and help us register your members. I mean, in most Caribbean nations, credit unions have 40 to 70% of the populations having accounts in the credit unions. So you would be a perfect place to help us in this matter. And just think about it. You get them to open a health savings account at the same time. Okay? That would go towards that, will create that environment. Part of the reason why we want you guys involved is you are part of the solution, to be honest with you. The credit union movement, the financial institution are part of that movement. And so, you know, the idea is that let's be creative. So when we are about to begin the development of the registration process, we would love somebody represented from your institution to participate in those discussions. Of course, we have to have the machines and have all those things to register people. This is nation building. We're building a nation one brick at a time. And obviously, we need your support. All right? Any more questions?
Percentage of persons subscribing to medical insurance has to do with the perception that we have about insurances. People don't trust insurance companies. And so some work has to be done there to try to have that paradigm shift and to understand. People don't understand how those insurances can benefit them. And I often tell members sometimes it's even better to have a medical insurance even before you can consider a life insurance, because so a lot of them have life insurance, but the medical insurance they don't trust. And it's because of some of the operations of the medical insurances as well, how long they take to honor claims, the excuses that they provide sometimes why they do not want to honor claims, and if you're very passive, they get away with it. So some work has to be done in terms of addressing the perception that insurance companies are not that beneficial.
That's a very good point. And obviously, they are aware of it, and they are at the table with us, part of that discussion. And again, when you sign a contract and you have stipulated terms with a body and an organization, they're going to honor it. The insurance company will honor it. Right now, the kind of policies that are set out is they set it in a way to comply with regulations. They set it in a way to make sure that they maintain a level of profitability. The truth is, insurance companies in this region don't make money on healthcare. They make their money on property and casualty. Obviously, they have the opportunity to invest the dollars that they collect as premium. But from the insurance part of it, they don't generate huge profits. What they do is they set it up in a way to preserve themselves. So now we have greater volumes, and you reduce the risk, and they don't have to cover all aspects of it. They will make a profit. It's going to be sustainable, and you have now a large organization, or an organization that's going to advocate for the consumers, the healthcare providers, in a way that it puts the insurance company in a place where they have to perform. I think the system fixes it. Fixes that problem. Any more questions? All right, so we have a little bit of housekeeping to do. San, you wanna?
We have the final survey. So Dr. Ned's going to that slide in the other direction. There you go. Or your